look now at magnesium and calcium. And the first thing I want you to do is write on the top of your page, they act like sedatives. Now everyone in here knows how a sedative makes you feel, right? First of all, look at the fact. Magnesium is excreted by the kidneys, but it can also be lost by other ways, like the GI tract. But the primary way to get rid of magnesium is through the kidneys. So if your kidneys are messed up, are you going to be able to get rid of your magnesium? No. So let's talk about hypermagnesemia first. Let's look at all the causes. First one is renal failure. I think you probably understand that. If the kidneys aren't working, they cannot get rid of the magnesium, so it's going to build up in their blood. Antacids have a lot of magnesium. As long as the kidneys are working, they will probably continue to excrete the excess magnesium. Anytime you have someone with hypermagnesemia, they probably already have a kidney problem. Now let's look at some signs and symptoms. And the first thing you see in that first column is flushing and warmth. Now those are some weird symptoms that go along with magnesium, and this is why. Magnesium causes us to vasodilate. Remember, that is why your teacher told you that magnesium is given to the PIH lady. Because in PIH, the blood pressure is really, really, really high. And when you give magnesium, it will cause the client to vasodilate, making their blood pressure do what? Drop. Also, the magnesium is going to prevent seizures in the PIH lady because magnesium works like a what? A sedative. Now, let me ask you this before we look at other signs and symptoms. We said magnesium acts like a what? A sedative. Now, do you see where it gives you a hint? Anytime you see magnesium or calcium questions, think muscles first, and you're going to get more questions right than wrong. Now, let's talk about all those signs and symptoms in the middle of the page. So, if I'm sedated, my deep tendon reflexes, tell me, are they going to increase or decrease? That's right, they're going to decrease. What is my muscle tone about to do? It's going to be weak and flaccid. Could I have an arrhythmia? Yes. What if I'm sedated? Now think about it. If I am sedated, my level of consciousness, my LOC is going to go down. My pulse is going to go down. And my respiratory rate is going to go down. Because we said mag acts like a what? A sedative. Now let's look at some treatment for hypermagnesemia. They may need a ventilator, right? It depends on their respiratory rate. If the respiratory rate goes below 12, they're going to get a ventilator. Respirations less than 12, they're toxic on magnesium. They might need dialysis because what did we say is probably not working? The kidneys. That's right. In fact, the kidneys may have caused the hypermagnesemia to begin with. Now, I bet your teacher always told you that any time you have a client with magnesium, something magnesium going on, you need to keep calcium glutamate available because calcium glutamate is the antidote for mag toxicity. Now, what does calcium glutamate do? Well, it reverses the respiratory depression and potential arrhythmias that would be caused by mag toxicity. Now, safety precautions because they are sedated. Now, let's look back up and look at hypercalcemia, okay? The other side of the page. Hypercalcemia, one of the causes is hyperparathyroidism. That means there's too much PTH, okay? When the serum calcium is low, the PTH kicks in and it pulls that calcium from the bone and puts it in the blood. Therefore, their serum calcium level will go up. Now, go over that phrase with your friend. When someone has hyperparathyroidism, that means there's too much what? PTH. Now, do you understand what's happening? Thiazides. It's just a fact that thiazides make us retain calcium. Immobilization will also affect calcium. Tell your friend how immobilization affects the bones. If we're immobile, will calcium stay in our bones? No, it's going to leave the bone and go into the blood. Okay, remember we have to bear weight to keep the calcium in the bone. Signs and symptoms. What kind of bones does this person have? Brittle. Yes, brittle bones. Do you understand why we might develop a kidney stone? Because their serum calcium is high, and the majority of stones are made of calcium. Remember all those signs and symptoms in the middle of your page? They're applicable to hypercalcemia because calcium acts like a sedative. Now, treatment for hypercalcemia. Well, first we want to get that client moving. When you get the client to move and bear weight, that's going to make the calcium leave their blood and return to their bones. We're going to give fluids to prevent what? A kidney stone. Fluids will help keep the calcium flushed out and prevent stones from getting larger. Now the next two things go together, phosphosoda and a Fleet's enema. These both have a lot of phosphorus. And you see, calcium has an inverse relationship with phosphorus. Now let's think about that. If I'm your client and I have hypercalcemia, that means my calcium level is really, really, really high, right? And my phosphorus level would really, really, really be low. So when you give me a phosphosoda or a Fleet's enema, you're building up my phosphorus levels, which is really sneaky because that is causing my calcium levels to go down. Is that good or bad? Good. Steroids decrease serum calcium, and we'll talk about that later. Now, what do we need to add to the diet? More phosphorus. Which foods have phosphorus in it? Anything with protein. Anything with protein has phosphorus. And yes, are you going to initiate safety precautions? I bet you are, because this person, remember, they are what? Sedated. Now, we must have vitamin D to use calcium. Where do we get vitamin D? From the sunlight. Vitamin D lives in our skin, but it's not activated until we get into the sun. Another thing, calcitonin. Calcitonin will decrease serum calcium. And when you give the drug calcitonin, what disease are you treating? Osteoporosis, because it is driving the calcium back into the bones. Now let's talk about hypomagnesemia and hypocalcemia. And at the top of the page, I want you to write, not enough sedative. Not enough sedative. Now let's look at hypomagnesemia first. Causes, diarrhea. We have a lot of magnesium in our intestines. So if we're having a lot of diarrhea, we're also losing a lot of magnesium. And probably the most frequent client that we see with hypomagnesemia is the alcoholic. You see, alcohol suppresses the release of ADH. And a decrease in ADH means this person will diurese. Alcohol is also a hypertonic solution, which will also make you diurese. Where do we get the majority of the magnesium that's in our body? From the food that we eat. Do alcoholics like to eat? No, they like to drink. And when you drink a lot of alcohol, what do? Retain or diurese? And don't act like you don't know. You diurese. So the alcoholic has two things working against him. They're not eating and they're diuresing a lot. Now let's look at signs and symptoms of hypermagnesemia. And remember, not sedated. If someone is not sedated, what kind of muscle tone will they have? Rigid and tight. Could they have a seizure? Yes. And that is what I'm scared of. They could have stridor, laryngospasms, because the airway is made of what type of muscle? Smooth muscle. A positive chavostics. Now show your friend how to check the chavostics. And don't hurt them. Now that's when you tap the cheek and it starts to twitch. Is that normal? No, that's hyperirritability. A positive trousseau is when you pump up the blood pressure cuff. And what does their hand do? It starts to tremor, right? That's not normal. Could this person have an arrhythmia? Yes, because remember, the heart is definitely a what? Muscle. Now, what are the DTRs going to do? Increase or decrease? Increase. Mind changes. Now that could be anything. On the page before, we said they were sedated, and we said the LOC was going to go down. But now they're waking up. They could be wild. They could be psychotic. They could be seeing things, or they could even be depressed. That's why we just say mind changes, because you never know exactly what their behavior will be. You can't predict. Swallowing problems can occur because their esophagus is a smooth muscle. And if the client has a problem swallowing, what is your number one concern with that client? Aspiration. Now let's look at our treatment for hypomagnesemia. Easy. Give them some mag. Check what function before and during IV mag. What do you think? We need to check their kidney function. Now let me give you a critical thinking exercise. Something to think about here. Let's say we are giving a client IV mag. Now you're checking their urine output just like you're supposed to, and their urine output at 10 o'clock was 180 milliliters. Now, an hour later, their urine output has dropped to 140. Now ask your friend, are you worried about that or not? Raise your hand. You have to vote, and vote proudly. How many of you are not worried? Okay, how many of you are worried? First rule, there are no happy test questions. A test question would not be a test question unless there was something for you to worry about. So by the time you leave this review, you're going to be worried sick, okay? So let me ask you again, how many of you are worried? Great, you've just made your first step toward passing the boards. But now in this critical thinking exercise, everything looks good, doesn't it? Okay? Think about it. I said their urine output has gone from 180 to 140. That didn't seem like a very big deal, did it? We don't normally worry about urine output until it's really low, right? In fact, probably in nursing school you were told you worry about urine output when it gets to what? 30 milliliters an hour? That's when you worry? But now remember, this is the NCLEX, and they want you to be a safe nurse. So, since this is the NCLEX, you should assume the worst. You should always assume the worst. So, if they give you data, assume something bad is happening. Now, remember, we have a client on IV mag. We're checking hourly output, and that has dropped from 180 to 140. I think we all know we're worried, but we may not know why we're worried. Okay? Now think about it. If our urine output has dropped from 180 to 140, ask your friend what they might be worried about. Is this client retaining something? What are they retaining? Mag. And that's what we're worried about, because magnesium acts like a what? A sedative. Now look in your box. Okay? You see 4 options. That's your critical thinking exercise. Take a look at those options and talk with your friend about what you want to do. Now there's something we have to warn you about. When you go into the testing center, did you know there's going to be someone there waiting for you? They're going to open the door and say, "Welcome to my testing center." Do you know who that will be? That's the devil. That is the NCLEX devil. The devil is going to be in every single question tempting you. Now tell me, when the devil tempts you, they're going to tempt you with something that looks good or something that looks bad. It's got to look good if you're going to be tempted, and that's why all 4 answers are going to look good. So let's look at these answers again. Let's say that you chose number 4. Let's reassess in 15 minutes. Well, this is what's going on. You've walked in the room, and there sitting on the side of the bed is the devil. The devil's with your client, and the devil says, "You go on. I'm going to watch her. She's going to be just fine. You're just going to be gone for 15 minutes. You know, go ahead. You go on." And then when you come back in that room, what is the color of your client? Purple, right? Even at this point, you have the housekeeping lady over in the floor mopping, and she even knows there's a problem, right? Okay, what has this person been retaining for the last 15 minutes? Magnesium. And mag acts like a what? A sedative. And that's going to make their respiratory rate go down. You know, does the devil want us, what does the devil want us to do to people? Harm people? Give them long-term residual damage? Might even want us to kill them. Every time you select an answer on the boards, you are sending a message to the NCLEX lady about the kind of nurse you're going to be. You only have one chance with each question to let them make a judgment about you, a judgment based on how you answered the question. Now, for those of you who chose answer 2, decrease the infusion, this is the message you're sending the people who write the test. I'm going to kill her slowly. Is this the message you want to send if you want a license? No, of course not. If there is even a chance they're retaining magnesium, you had better do what? Answer 3, turn off the infusion and run and get somebody who knows more than you do. They don't want you standing by the bedside with your 2 weeks of vast nursing knowledge trying to figure out a cure. No, they want you to get someone else that knows more than you. After you turn off the infusion, of course. You, as a brand new nurse, are supposed to say this. Okay, they've given me data. I know I should be worried. I know there's a problem. And when there's a problem on NCLEX, they want you to deal with it now. You know your client is getting mag sulfate, IV, and that urine output has dropped, and you know you must stop that infusion because their respiratory rate could become suppressed. Now, on the answer, call the doctor. There are times, that was answer 1, call the doctor. There are times when this is the only thing you can do. But here is the Hurst rule. If there is something that you can do to help the problem, do that first before calling the doctor. And finally, yes, we're going to place this person on seizure precautions, right? Because there is a chance they might have a seizure. And if their magnesium is low, well, you want them to eat foods high in magnesium, right? Where do we find magnesium? In spinach, flaxseed, cucumbers. See those things listed? Now, you have all heard that there are a lot of management and delegation questions on the test, right? Well, let's practice one of those. There are 2 nursing assistants down the hall, and they are both about to ambulate someone. The first nursing assistant is about to ambulate someone with a history of grand mal seizures. And the other is about to ambulate someone who is 8 hours post-heart cath. In which situation should the nurse intervene? Ask your friend. Everybody has to vote. How many vote for the grand mal seizure? What about the heart cath? What is the number 1 thing we should be worried about with a post-heart cath? Hemorrhage. That's right. So let me clarify something, because I know what some of you are thinking. You know, some of these clients, they would already be going home after this procedure, right? 8 hours. But the point is this. Could they still hemorrhage and bleed to death? That is why I'm worried about that, okay? Now, grand mal seizure. I know what you're thinking. What if they get out in the hall and have a seizure? Well, people with a history of grand mal seizure, they can walk, can't they? If they start having a seizure, what are you supposed to do? That's right, break the fall, take them to the floor, protect their head, turn them to the side so they don't aspirate. And you had better take notes, right? You better be taking some notes because you're going to be calling the doctor, and you can't call the doctor and say, ooh, it was bad. You should have seen it. You should have been here. You can't do that. So, are you going to pick heart cath or grand mal seizures? The heart cath is the right answer. Okay, back to treatment. What are you supposed to do when a client starts complaining of flushing and sweating when you start IV mag? Stop it if you want to get a license. And here's the deal. Those are normal signs and symptoms when giving IV mag, aren't they? But could they be a sign of worse things to come? Yes. And that's why we are going to assume the worst. Remember, test questions plus NCLEX equals a problem. Now, you may not know what the problem is, but remember, there's a problem. You take that sentence to an experienced labor and delivery nurse, and they're going to say, everybody who gets IV mag is going to be flushed and start sweating. But remember, they already have passed that test, right? Absolutely. Now let's go back up to hypocalcemia. Causes: hypoparathyroidism, a radical neck, thyroidectomy. Now out beside all 3 of those, I want you to write something down. Not enough PTH. If we do not have enough PTH, the serum calcium will go down. With a thyroidectomy or radical neck dissection, could the surgeon accidentally take out a couple of the parathyroids? Yes, and if they accidentally took out parathyroid, that person's not making as much PTH as they used to, right? So their serum calcium is going to go down. Now, all of those symptoms in the middle of the page, we have already gone over those, and they're applicable here too. So now let's look at treatment for hypocalcemia. Vitamin D to help utilize the calcium. Vitamin D to help utilize the calcium. Then there are 3 similar drugs: Renagel, Foslo, and Oscal. All are phosphorus-binding drugs. And when you bind phosphorus, the serum phosphorus will go down, which makes the serum calcium go up. IV calcium. Before you start giving someone IV calcium, you had better make sure they're on a what? A heart monitor. It says on your handout to give IV calcium slowly, because if you give it too fast, it can cause a heart arrhythmia. And I know, you are all excited. You cannot wait to practice CPR, right? But that's not nice. One thing IV calcium is going to do is slow this person down, because it acts like a what? A sedative. It decreases the heart rate, and it will also widen the QRS complex. And just between you and me, a certain degree of QRS widening is appropriate. Now, let's do an NCLEX critical thinking exercise. So, you are giving IV calcium. You have got them on a heart monitor. Now, let's look at the strip on your screen and watch what happens. Their PQRST is looking good. So, you give them a little more IV calcium. And remember, I said it would slow them down a little bit and widen what? That QRS complex. Now, do they want you to look at that and say, "Oh, look, it did widen that, just like the book said. That's weird. Let's give them some more. Oops, that's really wide." No, you didn't have to take the EKG class to know that's not good, did you? No. What did you just throw this person into? Death, asystole. So now what are you going to do? CPR, I hope. Okay, now let's talk about sodium. Yay. Your sodium level in your blood is totally dependent on how much water you have in your body. So circle water. This is the only electrolyte that cares about water. Now, your teachers told you that sodium follows water, but we've already said that there are times when they do not follow each other. Remember SiADH and DI? Also, hypernatremia and hyponatremia. If they followed each other all the time, we would never have hypernatremia or hyponatremia. Now, let's talk about hypernatremia. It is the exact same thing as dehydration. It's too much sodium and not enough water. Too much sodium and not enough water. Now let's look at the causes. There are 3 causes listed. Hyperventilation. Now why? Every time you exhale, what are you losing? Water. And your teachers probably called that insensible fluid losses. Heat stroke is another cause, and diabetes insipidus. Now, I didn't put the obvious things on there like vomiting and diarrhea because everyone knows that those things will cause dehydration. Now, everyone in here has had some degree of dehydration in their life. So let's think about signs and symptoms. That's why you probably had a dry mouth. You were thirsty because you needed water. Now, you probably did not have swollen tongue. That's weird, and it's only with severe hypernatremia. Neuro changes. Now, that's a biggie. In fact, I want you to write at the top of this page, sodium, think neuro changes. Our brain does not like it when our sodium is messed up. It doesn't matter if it's hyper or hyponatremia. A person can actually die and nothing be wrong with them other than their serum sodium being messed up. But when you look at electrolytes at the hospital, people don't always look at sodium, do they? What do they always look at? Potassium. Well, don't forget to look at the sodium. Now, treatment. Restrict sodium. Dilute the client with IV fluids. Diluting will make their serum sodium go down. If I vomited 10 times, Am I dehydrated? Yes. And they're going to start IV fluids on me to dilute my blood. And the more they dilute my blood, the lower my serum sodium levels will go. Daily weights and eyes and nose. If your client has a sodium problem, they also have a fluid problem. Don't forget to continue to monitor their lab work. Feeding tube clients, they can tend to become dehydrated. Now you see, it says on that can of Ensure, Total Nutrition. You know, it has everything they need to live, right? The protein, the electrolytes, the vitamins, the minerals, everything but one thing. What's missing? The water. Okay, there's another NCLEX critical thinking exercise for you. Let's pretend that we have someone on a tube feeding. When you have someone on tube feedings, you had better be watching their serum what? Sodium every day. And what is the normal serum sodium? 135 to 145. Now 2 days ago, the tube feeding client's serum sodium was 135. Yesterday, it was 137. And today, it's 139. Now all those numbers are in normal range, right? But what did you notice? Every day they're doing something. They're going up just a little bit. So to prevent dehydration, what should we do? Ask the doctor if we can give them more water with their tube feeding. And don't wait until it's out of range to do something. Do something ahead of time. Now, let's go back up to hyponatremia. This person is diluted. Too much water and not enough sodium. What would cause it? Drinking too much water for fluid replacement. When the client has been vomiting or sweating, you see, that's only going to replace the water and dilutes the blood. When a person is vomiting or sweating a lot, they lose fluid and electrolytes. If they're just drinking plain old water, did they replace everything that they needed? No, they didn't. They're going to become more diluted. What should they be drinking? Gatorade maybe to replace the electrolytes? Psychogenic polydipsia. With this disorder, the client loves to drink water. Remember, this is the psych client that likes to stay at the water fountain all day, and they drink so much water, in fact, it affects their brain. And that's what they like about it. We've all seen people in the hospital getting D5 and W, sugar and water. They can become diluted. Also, we have clients with SIADH. They will become diluted because they are retaining what? Water. What organ does not like it when the sodium is messed up? The brain. Signs and symptoms: headache, seizure, coma. Treatments. This client needs sodium. They do not need water. So let's talk about that last statement. If you have a client with neuro changes, because they're so diluted, they may need a big dose of sodium, right? That's when you're going to see the physician order something like a hypertonic saline. Anytime you see the word hypertonic, you should always think packed with particles. Things like 3% normal saline, 5% normal saline. See, your job is to figure out what the particle is. And if it's a hypertonic saline, then you know the particle is sodium. If you give someone a large amount of sodium right into their vascular space, remember, it's going to act like a sponge. So tell your friend, what are you worried about? That sodium will begin pulling fluid into what? The vascular space. And so now we're putting that client at risk for a fluid volume excess. That's why 3% normal saline is a very dangerous solution. In fact, in some hospitals, this solution would only be given in the ICU. Or you may have very specific protocols to follow if administering it on a regular floor. Also remember, anytime you're given large doses of sodium IV, give it slowly because the brain doesn't handle big shifts in this serum sodium. Okay, now that we've looked at hyper and hyponatremia, and since we love doing these critical thinking exercises, here's another one for you. Let's say you have a client. He's a marathon runner. I know, that sounds crazy. But that person is preparing for the race, and they're drinking 1 liter of water about every 15 minutes. See, they're trying to get prehydrated. And then, now they're running the race, and they're running and they're sweating, and they're drinking more water. Running and sweating and drinking more water. Ask your friend, what would you anticipate this person's sodium level to be? High or low? What do you think? And we've said they're sweating and running and drinking what? Only water. So their serum sodium levels are going to be low because we have someone, again, running and sweating, and they're diluting. They're just drinking water, so they're diluting their blood. And dilute makes numbers go down. And the only three numbers we think about are sodium, specific gravity, and hematocrit. Now here's another situation. Let's say you have Granny. She's cute, but she has Alzheimer's. Now Granny lives by herself, and sometimes she forgets to drink water. Could she forget all day long? Now tell me, she could be hyper or hyponatremic. What do you think? If Granny's dehydrated, her serum sodium levels are going to be high, right? She's hypernatremic. Will she be thirsty? Yes, she could be thirsty. And she could be hypotensive and weak. Could this lead to renal failure? Yes. No volume to perfuse those kidneys. Now, let's focus on potassium. Potassium is excreted by the kidneys. If the kidneys are not working well, the serum potassium levels, tell me, will they go up or go down? Go up. Hyperkalemia causes kidney trouble. Now, we all understand that. Aldactone can cause hyperkalemia because with aldactone, the client is retaining what? Potassium. Now, look at the signs and symptoms. Hyperkalemia begins with muscle twitching, proceeds to weakness, and then flaccid paralysis. Could your client develop a life-threatening arrhythmia? Yes, of course. Okay, let's think about this. Let's say you had a question and it asked you, which one takes priority? Which would you pick? Life-threatening arrhythmia or muscle weakness? That's right, life-threatening arrhythmia, right? Because that's the one that's going to kill you. See, on your test, you could get a lot of questions that use the word priority. And when you see the word priority, it changes the way you have to answer the question. One way to answer a priority question is to pick the killer answer. Muscle weakness, that's not going to kill anyone, but a life-threatening arrhythmia can. We're going to be practicing this throughout the review. Treatment. Now these are emergency measures. First of all, dialysis, because obviously the kidneys aren't working. Calcium glutamate to decrease arrhythmias. Glucose and insulin can also be given. You see, the insulin is going to carry the glucose and the potassium into the cell. That's right, the insulin carries the glucose and the potassium into the cell. Therefore, their serum potassium will drop. So anytime you're giving IV insulin, there are two hypos we need to worry about: hypokalemia and hypoglycemia. The next treatment is K-exolate. Now circle the K in K-exolate. The only time you will ever give K-exolate is when someone already has hyperkalemia. Anytime you see that drug, you know they already have hyperkalemia. How does it work? It exchanges sodium for potassium in the GI tract. Now let's think about that. The client has high potassium, so we're giving them K-exolate. So now they're exchanging the potassium for sodium in their GI tract. So we're increasing their sodium and bringing down their potassium. You see, sodium and potassium have an inverse relationship. Now, since we're increasing their sodium, what could they become? Dehydrated. Yes, they could become dehydrated. Now tell your friend, what could you do to offset dehydration? Push fluids. Pushing fluids. Now let's go back and look at hypokalemia. Causes: vomiting, NG suction. Remember, we have a lot of potassium in our stomach. So anytime we're vomiting a lot or we have NG tube hooked to suction, those people are losing potassium. Diuretics, I know you understand that one. And anyone not eating will not be getting potassium. Signs and symptoms. First, muscle cramps. Then muscle weakness. And last, arrhythmias. Treatment, we're going to give them some potassium. We could give them aldactone so they would do what? Retain some potassium. And of course, we're going to encourage them to eat more potassium. Now, a few things here listed in miscellaneous. What is the major problem with PO potassium? GI upset. That's right, GI upset. So we want to give it with food. Now, put a star by this next sentence. Assess urine output before and during IV potassium. You see, if the urine drops during the infusion, what are they retaining? Potassium. Could that kill the client? Yes. Be certain that your client has good urine output if you're giving them IV potassium. And always, always put it on a pump. Always put potassium on a pump. You have to have that. Mix it well. Move the bag around. Mix it well. Disperse it. And never give IV potassium push. It must be diluted in something. The physician will tell you what kind of fluid and how much fluid he wants it in. Is it going to burn in the infusion? Yes, it is, especially if it's a strong concentration, for instance. For example, you had 40 milliequivalents of KCl and 100 milliliters of normal saline to run over 4 hours. Do you think that's going to burn at that infusion site? Yes, because potassium eats up peripheral veins. Thank you. That concludes fluid and electrolytes.